Ma'am, we can start whenever you're ready.
I'm ready. Can you hear me?
Yes, we can.
Okay.
Okay.
I think we can get started. I'll start my presentation. So, first,
Yes.
I sincerely would like to thank Dr. Sonal Saxena and the entire Indian Association of Medical Microbiologists for this opportunity to share some experiences with our upcoming postgraduate students. So, thank you very much. I would be speaking about how the current surge of COVID 19 is being monitored primarily through the Pan India Respiratory Virus Surveillance Network of the DHR ICMR Virus Research and Diagnostic Lab Network. I will also give you some perspectives of the global trends, sequencing data, as well as what kind of vaccination policies for COVID 19 other countries have put in place. So, if you look at the current global spike in COVID 19 cases, this is a global data which is now available at the WHO website. So, WHO is now not promoting individual reporting of COVID 19 cases, but under the GISRS, which was the system which was set in place when the 2009 H1N1 pandemic had started. So, at that time, the GISRS had become very active, and now WHO recommends an integrated respiratory virus surveillance, particularly taking into account influenza and SARS-CoV-2. So they do not recommend standalone surveillance of influenza or COVID-19. They say do an integrated surveillance. So that's what we have started in India. But if you see in this integrated surveillance, you can see that there has been a peak. There is a global peak now that you can see in SARS-CoV-2, and this is data till May 2025. Fortunately, now this peak has started declining. And also, when you look at the recent COVID 19 cases on a weekly basis, there is again an upsurge, and you can see that it has started slightly declining very recently. So, this is as per the global surge that is being observed. Now, in India, what we are doing to monitor the COVID 19 cases. So, first of all, I would like to say that in the current situation, when SARS CoV 2 is now an endemic virus, there is no point in testing each and every patient as we were doing during the pandemic times. We just have to monitor the surge, take appropriate precautions if for elderly people, children, comorbids, immunocompromised, but we have to live our lives normally along with this virus, as we have started doing for influenza, as it has integrated into the seasonal ecosystem, the H1N1, so has SARS-CoV-2 also. So we really have to learn to live with this virus with appropriate public health precautions whenever there is a surge. So in India, through the DHR ICMR Virus Research and Diagnostic Lab Network, we have set up a tiered network of 73 sites all across the country, which you can see here on the map of India. This covers 27 states and 5 union territories. And all these sites that you see here, they actually keep on collecting samples from respiratory virus illness patients all through the year and keep on testing them for various viruses, which I will show you in the subsequent slides. So we have year-round data from 73 sites all across the country, wherein we keep on monitoring the trends of respiratory viruses throughout. And how do we monitor them? We do a multiplex testing, and this multiplex kit has been developed by NIV Pune. And we are testing for four major pathogens, that is influenza, both A and B, and SARS-CoV-2, respiratory syncytial virus in children and elderly. And in the states of West Bengal and Kerala, we are also testing for Nipah virus, because Nipah virus also presents as ARDS or SARI, and it is important to look for Nipah in these states. Then we further do virus isolation and characterization at 7 labs in this particular network. The apex lab is NIV Pune, and the data that we generate from this network is regularly fed into the global influenza database, which is known as the FluNet portal of WHO. Now, how does it help? Why does this data go into the FluNet portal? Because whatever characterization of influenza virus we do and the isolations that we do, when we give this data and the isolates to WHO, WHO includes this data while putting out the recommendations for influenza vaccine use for the northern and the southern hemisphere. We are in the northern hemisphere, so our data is contributed to the northern hemisphere vaccine recommendations. And the isolates that we give, they are distributed to various vaccine manufacturers across the world to develop appropriate vaccines. So this is a very useful network of 73 labs that we have been able to operationalize in India. And this network has very ably been able to detect the spillovers of avian influenza virus wherever we have found unsubtypable type A virus, influenza virus. We actually observed a spillover of H5N1 in 2021 July from West Bengal, and the case was tested in AIMS Delhi. In March 2024, we saw a spillover again in West Bengal of H9N2. And in April 2025, we saw H5N1, again a patient, a small child who died in AIMS BB Nagar. So this network has been efficiently been able to detect the spillovers of respiratory viruses other than normal influenza viruses. This also ably has picked up spillovers of avian influenza viruses. So this is how this network looks like. The Apex lab is at NIV Pune. Then there are referral laboratories, which are 7 in number. There are testing labs, which are 65 in number. So all the testing labs collect samples. And how do they collect samples is that they actually enroll 10 SARI patients every week from the hospital in which the VRDL is located. And they also collect 15 ILI or ARI samples from community settings. So for this, they have a tie-up with the community medicine department, and thrice a week, the VRDL staff goes to the community catchment areas of the community medicine department and collects 5 samples thrice a week, that is 15 samples every week from ARI or SARI patients. So 25 samples per week are collected from each of these 73 sites, and it is tested for the presence of respiratory viruses. Now, this is the basic activity of testing labs. Then what does a referral lab, in addition to the work of the testing lab, they are also into internal lab quality control exercises. They have started isolation of virus and characterization, and they are also conducting trainings. While as the Apex lab at NIV is the overall mentoring institute that we have in this system, and they are providing lot of capacity building and reagent support to all the labs of this network. So this is how it operates. Now, I've already described this, that 15 ARI samples per week are collected from community, 10 SARI samples per week from the hospitals, and these 25 samples by multiplex testing, they are actually tested for the presence of influenza virus, SARS-CoV-2, respiratory syncytial virus, Nipah, and very recently after the HMPV scare, human metapneumovirus scare, in January 2025, we have added testing for HMPV also. So this is how the testing happens, that out of the 25 samples that are collected by each of the VRDL, we actually test for influenza A, B, and SARS-CoV-2. This is a single multiplex PCR. Now, if there is influenza A or B positivity, then we further subtype it by a PCR2, and we detect whether it is influenza A H1N1, influenza A H3N2, influenza B Victoria, or Yamagata. Yamagata currently is not in circulation. Victoria is primarily in circulation. Then we do a third PCR in case we have H1N1 positive, and this PCR tells us whether we have oseltamivir resistance or not. For the respiratory syncytial virus, we actually also have a quadruplex PCR in the first step, but this quadruplex PCR is only used when we are testing RSV samples in people less than 5 years of age and greater than 65 years of age. So in this population, we use a quadruplex assay, but between 5 years to less than 64 years, we use a triplex assay. And we also further type respiratory syncytial virus into types A and B. So, and as far as the HMPV testing and Nipah testing is concerned, we are only doing this testing in SARI patients because the main concern is that how much severity HMPV would cause. That is what the major question was. So we were not very worried about HMPV. We know it circulates in ILI patients, but what is the intensity of severe cases or proportion of severe cases which HMPV would cause? So for that, we introduced HMPV testing in SARI patients, and we systematically collected samples from this. And fortunately, we did not find any significant association of HMPV with disease severity. And we are also testing for Nipah virus, presence of Nipah virus in SARI patients in West Bengal and Kerala. And we have not been able to pick up any Nipah virus positive case till now from this particular network. Now I'll come to the data analysis of these respiratory viruses which we are testing. And this data I'm particularly showing for this peak that we are experiencing right now, the COVID-19 upsurge. So if you look at the data from March 15 to May 31, this is how it looked like. That if we look in from 15th of March, all the respiratory viruses were in low circulation. And then all of them started rising, particularly H3N2. This dark blue is H3N2. And this portion that you see is Victoria. So there was no sign of COVID till week 12, that is the last week of March. And same was the case in first week of April when we are seeing a very faint band of COVID here. But then after first week of April, you can see this pink band that you are seeing here. This is SARS-CoV-2. The red one is HMPV and the topmost purple one is RSV. So here you see that SARS-CoV-2 has started increasing and it remained steady, particularly in April. But as soon as last week of April approached, we saw that SARS-CoV-2 started rising and it is continuously on a rising trend, wherein here, if you look in May, then it has actually completely replaced. But H3N2 has managed to circulate fairly well in spite of the SARS-CoV-2 peak here. Still, you can see a peak here. And this is our latest data from the last week of May, where again we are seeing a peak. Now, if we compare this data to what we saw last year in the same time frame, then the peak of SARS-CoV-2 we saw a little earlier. It started appearing from March, second week of March, we started seeing, though the respiratory viruses again were in low circulation, but SARS-CoV-2 again was predominating in mid of March last year. It kept on rising, 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 and subsequently it started falling in last week of May. So in this year, we are seeing a shift of perhaps 1 month in the seasonality of the virus, but we saw similar peak last year also. This is the point that I'm trying to make. And the bigger point is that these peaks will keep on coming and going. The respiratory viruses at one time point, like last year, you see that the circulation of H3N2 during this time frame was very, very minimal. But here, H3N2 has been significant and it has managed to circulate along with SARS-CoV-2. And even there is increase in proportion of circulation of type B Victoria as compared to last year. Last year, we only saw H1N1, some part of Victoria for some of the year, and SARS-CoV-2. So this is how the viruses keep on changing in terms of their coexistence, their dominance, but peaks will keep on coming and going. That's the larger point. And if we look at what is the virus-wise positivity, is there any difference in the virus circulation in samples of ARI which are being collected from the community versus SARI which are being compared from the collected from the hospitals? So this comparison tells you that the SARS-CoV-2 cases that we are seeing currently, predominant portion of these cases is ARI. that is acute respiratory illness. Whereas SARI samples, actually, there is almost a fourfold difference when you compare the community versus the hospital samples. So the community samples are fourfold more as compared to the hospital samples, which are positive for SARS-CoV-2. So this itself is self-explanatory that the cases that we are seeing for the COVID-19 currently are generally mild in nature. And even these 6.4% cases that you see here, many of them were actually patients who were admitted to the hospitals for some other condition, some other illness, or post surgery, or they were comorbid people. And even the gender wise positivity, if we look at it, so there's no difference in gender wise positivity. The bottom pink color is for females, and the top blue color depicts males. So if you look at the positivity, overall positivity in males and females, it's almost equal. And both in ARI and SARI patients, both in ARI and SARI patients, this positivity is almost equal. Now, if we look at the virus-wise weekly positivity in SARI patients, so this is what we see, the trend here is, and here at the top, you see the SARS-CoV positivity. Darwaza band kar de. SARS-CoV-2 positivity, it has been increasing weekly positivity even in hospitalized patients. And but definitely this has started declining. This is the data from 31st of May, but now it was eventually rising. But now the latest data, which I'm not depicting here because the week is not complete, has already started showing the declining trends. And this is again in acute respiratory illness patients, there has been a rise in COVID-19 cases, and which is again on a decline now. Now, we also tried to capture that what are the clinical details of SARI patients during this time frame, which I just presented to you from 15th of March till date. So this is the number under our surveillance. There were more than 5,000 patients who were hospitalized, and they were positive for some etiology, almost 10% of them. But the major proportion still was influenza. 7% of them tested positive for influenza, whereas less than 1.5% tested positive for COVID-19. So the point here is very important to note that though we are running after COVID-19, but it is more important to observe that influenza still remains a larger cause of hospitalization and SARI than SARS-CoV-2. So we often tend to neglect influenza because we are running after SARS-CoV-2, but you yourself can see that perhaps our approach is not the right one as far as weighing the severity of the viruses and the amount of attention that should be given. We don't propagate influenza vaccination. We don't even give it to high-risk groups. It's very dismally low as 1%, or even less than 1%, even in private sector, I would say. So this is something that really needs to be looked into. Now, even the ICU admissions happened in 12% of the patients, and 6% of the positive patients were actually given ICU care. Again, influenza was 4.5 fold higher as compared to SARS-CoV-2 when it came to ICU admissions. Oxygen requirement also was definitely much larger in patients infected with influenza viruses, either A or B, as compared to SARS-CoV-2. And ventilatory requirements were also definitely high. Now, there were very few deaths. We observed only 2 deaths in patients infected with SARS-CoV-2 out of this major denominator of 5041, and 8 patients died of influenza. So this is what our clinical outcome data shows. This is just to give you a glimpse of, this is an online portal which we have developed at ICMR National Institute of Epidemiology at Chennai, where we very systematically capture data from all these sites. And this is just a glimpse. Otherwise, there are 73 sites We are getting the clinical details of the patient, influenza vaccination history, as well as the outcomes we are really trying to capture. These are few papers that we have been able to publish, and a few more are coming up along with all our colleagues from the VRDL network. So this is just a glimpse of that. Now, talking about what have been the genomic sequencing data across the world and how are we comparable in India or how are we different? So, according to WHO, if you look at the genomic sequencing data of SARS-CoV-2 strains, then between January and May 2025, there were shifts in global SARS-CoV-2 variant dynamics. At the beginning of the year, the most prevalent variant tracked by WHO at global level was XEC, followed by KP.3.1.1. These are all sublineages of Omicron. Now, in February, circulation of XEC began to decline, while that of LP.8.1 increased, with this one becoming the most detected variant in mid of March. But since mid of April, the circulation of this variant LP.8.1 has been declining, and this variant NP.1.8.1 is increasingly being detected. Now, the most recently designated variant under monitoring is this one only. That is NB.1.8.1, which is a descendant lineage of XDV.1.5.1, in turn a descendant of JN1. So this XDV is a descendant of JN1 and NB is a further descendant of XDV. So whatever we are seeing now globally are the sublineages of JN1 only. And this is the graph which really shows you that over time how these lineages and different lineages of Omicron have been prevailing, have been replacing each other, with this recombinant NB.8.1 now predominating. And this is data which I actually extracted from GISAID. That is the global influenza surveillance website where all the global sequencing data is deposited, and many of you would be aware of this. So here also they report that NB.1.8.1 is the predominant lineage as per the different sequences that have been submitted by countries across the world. So here also, according to the GISAID data, you can see that this particular sublineage is predominating. And this is the genomic sequencing update from India. This sequencing has been done by ICMR, National Institute of Virology. So still we are seeing some lineages, though we are seeing NB.1.8.1. There are more sequences which are being done currently, but in India, the predominant pangolin lineages that we are seeing are XFG, JN.1.16.1, and LF.7.9. And this is the latest sequencing data, more, and you can see the names of the states from which these samples have been collected. And again, all these are sublineages of Omicron. Some are predominating and they keep on replacing all the time. The XFG is a recombinant strain. Otherwise, all of them that you are seeing on this slide, at least till number 10, they are all sublineages of Omicron and JN1. This is also to show you what is the data on wastewater surveillance showing. So ICMR is not conducting wastewater surveillance. This data has been very courteously provided by Tata Institute of Genomic Sciences, Bangalore, Dr. Rakesh Mishra. This team is regularly doing wastewater surveillance for SARS-CoV-2 in Bangalore and Vijayawada. And you can see that here the data depicts the trends from 2024 January till date. And this data itself shows that obviously there was a peak last year also in January, but we had a much sharper peak this year. It was a little delayed in terms of, first of all, we saw a peak between April and May. That is the last week of April, I would say. And now in June, May end, we saw a major peak, and now the trend is falling as far as the wastewater is concerned. And similarly, this is the wastewater graph of Vijayawada, which is again provided by Tata Institute of Genomic Sciences. wherein they saw this, various prevailing trends of SARS-CoV-2. And again, it peaked in third week of May, and now it is seeing a slightly declining trend. The updated data of June would be coming in a day or two from this particular site. Now, what are the common symptoms of JN1 variant? So, as per the global reports, so far, most of the infections caused by JN1 variant have been mild in nature. And the symptoms are very much similar to what you have seen in the previous Omicron subvariants, but the exact pattern may vary from people to people. The common symptoms here are fever, which is generally mild and short-lived. Cough is dry with slight phlegm. Sore throat is often one of the earliest signs. And runny or blocked nose, similar to common cold. Fatigue happens, headache happens, and there are obviously a feeling of malaise. And some patients also have GI symptoms, as we saw earlier in COVID, like diarrhea and nausea. But particularly loss of taste or smell, which was common with earlier variants, is less frequently reported with this strain of JN1. Now, what is WHO statement on the antigen? So I'll just give you a brief glimpse of the vaccine policies that the global agencies are talking about. So WHO in 2024 April issued a statement on what should be the antigen composition of COVID-19 vaccines. So they say that obviously the SARS-CoV-2 will continue to circulate and evolve, and there will be important genetic and antigenic evolutions in the spike protein. And the objective of an update to COVID-19 vaccine antigen composition is that the immunity that is induced by the vaccine should be able to combat the circulating strains of SARS-CoV-2. So as the virus is expected to continue to evolve from JN1, the tag of WHO advises that a monovalent JN1 lineage vaccine or JN1 lineage as the antigen in future should be considered in formulations of COVID-19 vaccines. Unfortunately, in India, we do not have any JN1 vaccine. We have a BA2 vaccine which is an mRNA vaccine, but the manufacturer in India has not updated it because of no demand of the vaccine, neither in public sector nor in government sector. So if there is a demand, definitely there can be a supply. The manufacturers are well attuned to it. Now, in accordance with WHO SAGE policy, vaccination programs should continue to use any of the WHO EUL or pre-qualified COVID-19 vaccines, and vaccination should not be delayed in anticipation of access to vaccines with an updated composition. So what they are trying to say is that if you are a high risk individual, you should actually take whichever vaccine is present in your country. You should not wait for the, like today we should not wait that when, if we will have an NB.1.8.1 vaccine, then only we will take it. We can take any vaccine globally which has a JN1, which is actually effective against JN1 lineage. Now, WHO also developed a roadmap on uses of COVID-19 vaccines in the context of Omicron and high population immunity. And this policy paper, I have given a link of that policy paper in this slide here. It actually describes an approach to optimize the global impact of COVID-19 vaccines at a time when Omicron and its sublineages are the dominant circulating variants of concern, based on public health goals, evolving epidemiology, and increasing population level immunity. Now, if you look at what WHO Strategic Advisory Group recommends, and this is very specific to immunization, then what are the kind of populations who should get vaccinated? They talk about, and you can see this, all adults, children. So people who have never received any COVID-19 vaccines, they say that all adults should receive. Children and adolescents only who have comorbidities, healthcare workers, pregnant women, any individual who is immunocompromised. So they become populations with special consideration. And these red ones are the high priority group. They have previously received one dose of COVID-19 vaccine, But if still they are above the age of 75 years, above 50 years with comorbidities, and any individual who's immunocompromised, again, adults who are this much old with comorbidities, healthcare workers, pregnant women. So they have actually defined which are the groups which should get vaccinated and the number of doses that they should receive. So this is the recommendation of WHO SAGE. CDC US also has a recommendation on COVID-19 vaccination, wherein they say that everyone aged 6 months and older should get a COVID-19 vaccine. It helps to protect you from severe illness and death. And they also recommend for people who are at high risk or never received a COVID vaccine, it's especially important for them to get a vaccine. They also emphasize that vaccine protection decreases over time. So it is important to go for an yearly vaccination kind of a schedule. And they have also been able to track that how many adults are taking vaccine in different years. So 49% of adults 75 years and older received the vaccine in 2024, whereas the same percentage was only 30% in 2023. So they have seen increase in number of people who are opting for COVID-19 vaccines. Similar recommendations have also been made by other countries like Canada, USA, and Australia. And this chart tells you, and generally they are talking about people who are above 65 years and high risk. High risk are those who are comorbid, immunocompromised, healthcare workers, household contacts, etc., etc. So every country has their policy. Every developed country, I would say, have a policy for COVID-19 vaccination now. So way forward for India would be that we must continue our robust surveillance for acute respiratory illness and severe acute respiratory illness to monitor the trends of respiratory viruses, and this should be backed by very robust efforts of sequencing so that we are able to monitor the strain. And India must formulate recommendations, its own recommendations of COVID-19 vaccination, as other countries have very timely done that. So that's all from my side. Thank you very much for the patient listening.
Thank you, Dr. Nivedita. It was, I think, one of the most informative talk that I've heard. And you're always such a gem. Thank you so much for helping me out in this talk. And I was constantly getting queries as to which subtype it is. Do we need to take a booster vaccination? So my question to you would be that there is no, as per whatever you've told us just now, I don't think any country recommends a booster again for this. Not even with the current situation, but otherwise, do you think any country's recommended booster?
Yeah, so Dr. Sonal, that's a great question. And that's what I tried to explain in the last few slides. That the countries like US recommends an yearly vaccination for COVID-19 now for the high risk groups. And so do many countries. And I showed all those high risk groups.
Yeah, in the last slide.
And
Yes.
they are also very closely working with their vaccine manufacturers to update the composition of the vaccine. So today, I just spoke with the Genova company person yesterday, and I talked to them. They are not making any vaccine. They have a BA2 vaccine, which they last developed for Omicron. But since there was no uptake or no demand from public-private sector, they have not updated their vaccine strain. So it's really time for us to think together and perhaps work with the government authorities, Ministry of Health and Family Welfare, to put out a policy for COVID-19 vaccination. So that's what is the way forward. And many of the developed countries have already done that. And WHO also kind of speaks about it. And it would require flexible mechanisms as we have for influenza vaccines, updating their composition periodically and doing very simple studies to see the effectiveness of these vaccines.
Right, because most of the time, what happens is that even whatever morbidity we are seeing or mortality that we are seeing is in people with comorbidities or extremes of age. So at least we need to protect them, I believe, rather than.
Exactly. It's only for high risk groups, not
Hmm.
for all population types, which are comorbid, extremes of age, those kind of things.
Right. So thank you so much again. If there are any questions anybody would like to ask, you can please unmute yourself and ask, or put them in the chat box. Anybody would like to ask anything to ma'am? I think ma'am, the talk was so crystal clear. After every this thing, I kept on thinking, now this will come, now this will come, and you covered everything. Thank you so much.
Thank you so much, Dr. Sonal. Thank you for the
Mm.
opportunity.
Thank you. So I think we'll not keep you busy anymore. There are no questions. That shows that it was such a clear, crystal clear talk.
It can be
Thank
the
you.
other way around also.
No, no, ma'am. It's more of a, it's more of the current situation, because everybody believes what is there in the newspaper and on the WhatsApp university. But to hear it from you, I think most of us have gained a lot. Thank you so much again.
Thank you so much. Thank you for the opportunity.
All right. Thank